Hello everyone, I am myself Dr. Rajesh Gubba. In this particular session, I will be discussing a very important topic in the cardiology, that is the treatment of the heart failure with reduced ejection fraction. So when do we use the term heart failure with reduced ejection fraction? We use this term when the ejection fraction of the individual is less than 40% having heart failure. Then we use the word called as heart failure with reduced ejection fraction. Now let me discuss the treatment of these individuals. So first, what will be the overview of this topic? So I'll be discussing what exactly is the pharmacotherapy we give for the heart failure with reduced ejection fraction. So for heart failure with reduced ejection fraction, we have two options. One is the pharmacotherapy, and then we also have some interventions. We also have some interventions in the treatment of heart failure with reduced ejection fraction. So in this particular session, I'll confine my discussion only to the pharmacotherapy. Then what exactly is the progressive decline in mortality with pharmacotherapy I'll be discussing, and what will be that pharmacotherapy? That is mainly neurohormonal antagonism. So this will be the overview of the topic. And what are all the various groups of drugs, or what are the various drugs that we will be discussing in this? Let me just give you a basic idea. So the drugs which I'll be discussing in this particular session will be about the neurohormonal antagonists, that is ACE inhibitors, angiotensin receptor blockers, and as well as the mineralocorticoid receptor antagonist, that is aldosterone receptor antagonist, that is the spironolactone, and as well as the eplerenone. Then the another important form of neurohormonal antagonist is the beta blockers. Then we have angiotensin receptor blockers, neprilysin inhibitors, that is valsartan plus sacubitril, SGLT2 inhibitors, that is empagliflozin and as well as canagliflozin. Then, so these are the group of drugs, they will reduce the mortality and they will improve the survival. And we have some other group of drugs which are also used in the treatment of heart failure with reduced ejection fraction, but they don't improve the survival, but they will improve the symptomatology related to the heart failure. And what are those group of drugs? That includes the vericiguat, which we'll be discussing that in detail, then omecamtiv mecarbil, then the endothelin receptor antagonist, and so on. But these drugs are very, very important in reducing the mortality, that is up to your SGLT2 inhibitors. So now let me take up the discussion one by one. Now if you see the treatment of the heart failure with reduced ejection fraction, so how does it evolve? It evolves from the point of renocentric. What is that renocentric? We give diuretics. What is the purpose of giving diuretics? That is mainly to reduce the congestion. And this particular diuretics, right, they are basically renocentric. It is through the kidney, the fluid which is overloaded in the body will be excreting out. And the next important is the hemodynamic therapy model. What is that hemodynamic therapy model? Is that we give inotropes. And what is the purpose of giving this inotropes? That is mainly to increase the cardiac output and as well as increasing the blood pressure. And then digoxin. So what I wanted to tell you is, how did the evolution of the treatment in case of heart failure with reduced ejection fraction started with? So initially, right, we were just supplementing only the diuretics and as well as the inotropes and digoxin. That was causing only symptomatic control, but they were not improving the survival. So from this point of renocentric and hemodynamic therapy model, now the progression of the treatment has gone into a state of the disease modifying therapy. Now what will be these drugs in the disease modifying therapy? The drugs in the disease modifying therapy will be neurohormonal antagonists, right? That will be neurohormonal antagonists. So if you see this neurohormonal antagonists, these neurohormonal antagonists, they include the ACE inhibitors, angiotensin receptor blockers, then we have beta blockers, then we have mineralocorticoid receptor antagonists, that is aldosterone antagonists are being present. So this will be the neurohormonal antagonists, right? So this is how the evolution of the treatment is, right? That is from renocentric and hemodynamic therapy model to disease modifying therapy, right? So now if you take the pill pillars of the pharmacotherapy, right, for the heart failure with reduced ejection fraction. They include, number one, that is inhibitors of the RAS, that includes ACE inhibitors, angiotensin receptor blockers, then mineralocorticoid receptor antagonists. Then the beta adrenergic receptor blockers, which will block the sympathetic activity, SGLT2 inhibitors, and as well as neprilysin inhibitors. These are the new molecules which have been added in heart failure with reduced ejection fraction. So these drugs, what is the importance of these drugs? They will reduce the mortality, right, and they also increase the survival of the individual, right, and they also improve, right, they also improve the quality of life within the individual. And these particular drugs, they reduce heart failure hospitalization, right, they reduce the heart failure hospitalization. And so these are all the advantages of this particular group of drugs. So they inhibit the cardiac remodeling, and they will improve the survival, and they will reduce the mortality. So these are the list of drugs, right, which we will be discussing in detail about them. Now let us start with the neurohormonal antagonism. What do? They reduce the mortality. And if you take the percentage wise also, now for suppose if you are supplementing only ACE inhibitors to the patient of heart failure with reduced ejection fraction, what is the percentage of reduction in the mortality? It is just only 23%. But whereas if you are giving a combination of beta blockers and the ACE inhibitors, then what is the percentage of reduction in mortality? Is almost 35%. So always the add-on therapy along with ACE inhibitors, if beta blockers are also added, then the chances of reduction of the mortality is much more, right? Then coming to the non-inferiority trials, where ACE inhibitors have been used in patients with heart failure with reduced ejection fraction, making ARBs a suitable alternative. See, some group of individuals, they cannot tolerate the ACE inhibitors. Now, what are the problems with the ACE inhibitors? Number one is the dry cough, because your ACE enzyme, that is very much required for the metabolism of your bradykinin. Now, when your ACE enzyme is inhibited by your ACE inhibitors, the bradykinin level increases and the individual will develop dry cough. And not only dry cough, the individual will also develop angioedema, right? So those individuals who cannot tolerate this cough and as well as angioedema, in them you need to give the angiotensin receptor blockers, that is your sartans, valsartan, telmisartan, olmesartan, candesartan. So ARBs should be given. So now there have been many trials, right, many trials showing that like the efficacy of ACE inhibitors is almost similar to that of the angiotensin receptor blockers. So what this study says is, if the ACE inhibitors cannot be tolerated by the individual, you can supplement the angiotensin receptor blockers in these individuals, right? And this particular group of drugs, that is ACE inhibitors or ARBs, they are given in patients with, right, they are given in patients with full spectrum of the heart failure. Right? What do you understand by the word full spectrum of the heart failure? That means it is given in all the functional capacities of NYHA. So it is given in NYHA class 1 to class 4. Because you take beta blockers, we cannot give when the individual is in state of NYHA class 4. But the ACE inhibitors or ARBs, like they are completely safe drugs in the entire spectrum of the heart failure, right? Now, when you are giving this neurohormonal antagonist, right, you are giving beta blockers, you are giving ACE inhibitors or ARBs, or you are giving mineralocorticoid receptor antagonist. See, what may happen is, due to the because of starting of this neurohormonal antagonist, there can be development of hypotension, right? And there can be also worsening of the heart failure, right? There can be also worsening of the heart failure, and there can be also progressive renal insufficiency, right? There can be also progressive renal insufficiency. So these are the things which cannot be tolerated, that is hypotension, worsening of heart failure, and impairment of renal function. If because of these parameters, if you are unable to start the neurohormonal antagonist, that is suggestive of a poor prognostic marker, right? That is suggestive of a poor prognostic marker. So one of the poor prognostic marker for heart failure is what? Inability to start neurohormonal antagonists because of hypotension or because of renal impairment. Okay, and this tells you that it's a cardinal manifestation of, right? It is a cardinal manifestation of transition to advanced heart failure. Right, it is a cardinal manifestation of transition to the advanced heart failure phenotype. So, like, this is a prognostic marker, which one, if you are unable to start the neurohormonal antagonist because of hypotension or renal impairment, that tells that the prognosis of the individual is bad, right? Then, coming to the class effect and as well as the sequence of the administration. Now, you take ACE inhibitors and as well as ARBs, all the drugs of ACE inhibitors, all the drugs of ARBs, they are very much efficacious in heart failure with reduced ejection fraction. That means your ACE inhibitors and ARBs, they have what is called as the class effect. That means all the drugs in that class are efficacious in heart failure with reduced ejection fraction. But it is not the same in case of the beta blockers. See, beta blockers, there are certain beta blockers, they cannot be given in patients with heart failure with reduced ejection fraction. So, like in case of the beta blockers, there is no class effect. Now, let me tell you also an example. What are those group of beta blockers which should be avoided in heart failure with reduced ejection fraction? Like, we have some beta blockers which have intrinsic sympathomimetic activity. What are those drugs? That includes, example, that is xamotyrol. This is one particular drug which has intrinsic sympathomimetic activity. And the another important drug is bucindolol. So, these two drugs, remember, they have intrinsic sympathomimetic activity, and these two drugs, they does not, right? They does not demonstrate the survival benefit. Right? They does not demonstrate the survival benefit. So that is the reason why these two drugs should not be given in heart failure with reduced ejection fraction. Then, which group of drugs can be given in heart failure with reduced ejection fraction? So, just remember this mnemonic, that is BMC, that is your Bangalore Medical College or Bombay Medical College, whatever the way you want to remember. But remember this BMC. So, bisoprolol, then metoprolol, and then carvedilol. And again in metoprolol, you have two formulations. Metoprolol succinate is there, metoprolol fumarate is there, right? What we need to give is, we need to give metoprolol succinate. So these group of drugs, they have been proven to improve, right? They have been proven to improve the survival in the clinical trials. Okay, whereas these two drugs, that is xamotyrol and as well as bucindolol, even though they are beta blockers, they have the intrinsic sympathomimetic activity. That is the reason why they should not be given, right? Next, now the next important point is whether to start the drugs individually or like we need to add the neurohormonal antagonist sequentially, or simultaneously do we need to add all the all the neurohormonal antagonists. So there was a study for that. So what was the study? That is CBIS-3, that is cardiac insufficiency bisoprolol study. Right? What these studies done was whether beta blockers or ACE inhibitors should be started. Right? So which one to start first? Is it the ACE inhibitors to start first, or is it like beta blockers to be started first in order to improve the survival of the individual? Right? What this particular study has given the result is the outcome did not vary based on the sequence of drug initiation, whether you have started ACE inhibitor first or whether you have started beta blocker first, right? That did not matter at all. Outcome was the same whether you have started ACE inhibitor or beta blocker first. Okay, so we can also add simultaneously or we can also add sequentially depending upon the blood pressure of the individual, because these neurohormonal antagonists, if the systolic blood pressure is less than 90 millimeters of mercury, you cannot give this neurohormonal antagonist, right? So what this CBIS 3 study says that whatever you might start either beta blockers or you might start ACE inhibitors, whatever might be that, but the efficacy is same, the outcome is same, right? Now later came the discussion on the dose and as well as the outcome. Whenever you are giving this particular neurohormonal antagonist, right, there were the trials which have been done whether to give high dose versus whether to give low dose, right? There were the trials done for ACE inhibitors, there were the trials done for the beta blockers, there were also the trials which were done for the angiotensin receptor blockers as well. Now you take Atlas trial. Atlas trial is the one which is done for the AC inhibitors, right? Then the HEAL trial. The HEAL trial is that which is being done for the angiotensin receptor blockers. Then we have the MOCA trial or MOCHA trial. MOCHA trial is that which is being done for the beta blockers. So what these studies have shown, the Atlas trial or the HEAL trial or the MOCHA trial, what these particular studies, these trials have shown that is, when you are starting these drugs in a very high dose, right, when you are starting these drugs in a very high dose, the maximal dose of these drugs when you are giving, then only there was lower rates of death, right? Then only there was lower rates of death, then only there was lower rate of heart failure hospitalization, right? Then only there were lower rates of heart failure hospitalization. So this is about the trial saying that high dose when you give, the survival would be better and mortality would be less, right? Now, what the clinical experience suggests that is the absence of the symptoms. What are those? That is absence of symptoms due to hypotension. What would be the symptoms due to hypotension? Fatigue and dizziness. So the absence of the symptoms suggests that pharmacotherapy may be uptitrate. You have to uptitrate this dose every 2 weeks. That means you are giving high dose. According to these trials, what we have discussed, you have to give high dose. But what the study have shown is, if there is no symptoms of hypotension, then you have to increase the dosage of the drug every 2 weeks to a maximum dose, right? To a maximum dose. Okay. So that is what is your trial saying. You have to give maximum dose of that particular group of drugs until unless if the individual is asymptomatic, and you have to titrate it every 2 weeks. Okay. Next, then followed by that, the another group of drugs apart from ACE inhibitors, angiotensin receptor blockers, and then beta blockers, then we have the mineralocorticoid receptor antagonist. So when you add this mineralocorticoid receptor antagonist, right, to the ACE inhibitors and as well as to the beta blockers, what has been shown is the mortality was further reduced by the addition of the mineralocorticoid receptor antagonist. Okay, but you have to add this only in cases of symptomatic heart failure. Okay, so symptomatic heart failure means where the heart failure with reduced ejection fraction of class 3 or class 4 NYHA, right, of class 3 or class 4 NYHA. So in this scenario, you can add mineralocorticoid receptor antagonist. Further reduction in mortality is very much good. Now, whenever in case of heart failure with reduced ejection fraction, what will happen to the aldosterone levels? It increases. Why? Because there is activation of RAS as a compensatory mechanism. So aldosterone is elevated. So this elevated aldosterone levels in heart failure with reduced ejection fraction, it will promote the sodium retention, right? and it will also cause the potassium excretion, that is hypokalemia. Now this sodium retention, that will cause the endothelial dysfunction, right? It will cause endothelial dysfunction, and this endothelial dysfunction is the one which will cause the myocardial fibrosis. Okay, so this will contribute, right? This will contribute to myocardial fibrosis. Okay, and the another important point that you need to remember is that whenever you are giving these drugs, that is the aldosterone antagonists that like spironolactone, you need to be very careful about the hyperkalemia, right? Because aldosterone antagonist, spironolactone, eplerenone, both of them, they will increase the potassium levels. So you need to monitor the potassium, and at the same time you also need to monitor the renal function. Okay, as such, aldosterone will not cause your renal failure, or your aldosterone antagonist will not cause renal failure, but in case of renal failure, the potassium levels keeps on increasing. And in a renal failure patient, if you are giving aldosterone antagonist, hyperkalemia will further get precipitated. So you need to monitor the potassium, and you also need to monitor the renal function of the individual. Okay, right. So that is about the story of your aldosterone antagonist, and examples are what? That is spironolactone and as well as the eplerenone. And what is the name of the trial which showed that spironolactone is very much useful for heart failure? That is the RALS trial. So what is that RALS trial? That is randomized aldosterone evaluation study, right? So this is like the most commonly utilized agent. Where do we give this? In scenario of heart failure with reduced ejection fraction and NYHA, right? And NYHA class 3 to 4, right? NYHA class 3 to 4, we can give this spironolactone. Then what is the purpose of adding eplerenone then? I'll tell you, because spironolactone is associated with certain adverse effects. If those adverse effects develop in the place of spironolactone, you need to add the eplerenone. Okay, so you take this eplerenone, it is studied in milder NYHA symptoms also. So even if the individual is having NYHA class 2, then also you can give this eplerenone, right? And this particular eplerenone, NYHA class 2, and this particular eplerenone should be given in milder classes of NYHA class 2, or if there is left ventricular dysfunction secondary to myocardial infarction. Secondary to myocardial infarction, if there is development of left ventricular dysfunction, then also you can give this eplerenone. Now, what is the advantage of the eplerenone over the spironolactone? Remember, spironolactone, it has the anti-androgenic property, whereas eplerenone, it has no anti-androgenic property. That is the reason why the adverse effects like, right, that is the reason why the adverse effects like gynecomastia, right, then erectile dysfunction, then decreased libido, these are not seen, right? These are not seen with eplerenone, but with spironolactone, because it has the anti-androgenic property, right? The spironolactone is associated with these adverse effects. Okay, right. So that is about your ACE inhibitors, ARBs, and mineralocorticoid receptor antagonists. Now let me discuss about this RAS therapy and neurohormonal escape. Right. Now, what do you mean by this word neurohormonal escape? This angiotensin 2, which can be generated by multiple non-ACE pathways also. What are those? I'll tell you. So your angiotensin 2, whatever has been generated by your RAS pathway, that can be inhibited by your angiotensin converting enzyme inhibitors, and the action can be inhibited by angiotensin receptor blockers. The action can be inhibited by the mineralocorticoid receptor antagonist, that is the angiotensin 2, which is being formed from RAS pathway. But what do you mean by this word neurohormonal escape is this angiotensin 2 can be also formed by non-ACE pathways. So when angiotensin 2 is formed by non-ACE pathways, the ACE inhibitors or angiotensin receptor blockers or your mineralocorticoid receptor antagonist will not be useful. Now, what are those non-ACE pathways by which the angiotensin 2 is being formed? It includes the following pathways. That is the kinase pathway, cathepsin pathway, serine protease pathway, and then non-enzymatic pathways. So these are the various pathways by which the angiotensin 2 can be formed, right? Then in such case, how to neutralize the effect of the angiotensin 2? So angiotensin 2, where it will act? It will go and act on angiotensin 2 receptor. Okay, that is angiotensin receptor. Yes. Now, some of the studies have shown that when you give the combination, see, your angiotensin 2 is being formed from non-ACE pathways also. These are all the various non-ACE pathways. Now, how to neutralize? Because the angiotensin 2 which is being formed by non-ACE pathways, that angiotensin 2 cannot be neutralized by your ACE inhibitors, right? That angiotensin 2 cannot be neutralized by ACE inhibitors. Then, what some studies have shown is, in order to overcome this neurohormonal escape, right? You are giving ACE inhibitors, but angiotensin 2 is still formed. That is an escape phenomenon by which your angiotensin 2 is formed. And what are those escape phenomena? These are all the escape phenomena. Now, in order to neutralize that, you need to give a dual blockade, right? You need to give a dual blockade. So what will be the dual blockade? That dual blockade is, you give ACE inhibitors that will neutralize the angiotensin 2 which is being formed from RAS pathway. Then you need to give angiotensin receptor blockers that will neutralize the angiotensin 2 which is being formed by non-ACE pathways, right? Which will be neutralized by non-ACE pathways. Okay. So some studies showed, right? What are those studies? Like we have Val-Heft trial, then CHARM-ADDE trial. What these particular trials said, I'll tell you. So Val-Heft trial means that is valsartan heart failure trial, and your CHARM-ADDE trial is candesartan in heart failure assessment of reduction in mortality and morbidity trial. Okay, so this is Val-Heft trial and CHARM-ADDE trial. See, what these two trials said is, you add angiotensin receptor blocker to the ACE inhibitors, right? You add angiotensin receptor blockers to the ACE inhibitors. These particular trials have shown that there is reduction in the heart failure hospitalization. Right? There is reduction in heart failure, the hospitalization. Understood? But whether to continue this combination in long term, the evidence was not there. Right? Whether to continue the combination for long term, it was a question mark. Okay. Now, later some more trials said that this combination should not be given. These two trials said go ahead with this combination. But we have the trials like the Valiant trial, and next we have Atmosphere trial. What these trials said, I'll tell you. So, Valiant trial, what is this? Valsartan in acute myocardial infarction trial. So, this particular trial, it has taken angiotensin receptor blocker, that is valsartan, okay, and it has taken the ACE inhibitor, that is the captopril. So this particular combination, right, this particular combination was given in heart failure with reduced ejection fraction secondary to myocardial infarction, right? This combination was given in heart failure with reduced ejection fraction secondary to myocardial infarction. So when this combination was given, this combination showed there is increase in the adverse events, right? There was increase in adverse events compared to, right, compared to monotherapy. Right, compared to monotherapy, this combination showed that there is increased adverse events. What was that increased adverse events? Right, there was this combination associated with severe form of hyperkalemia, right? And this combination also cause severe renal failure. So that is the reason why the Valiant trial said don't give the ACE inhibitors with angiotensin receptor blockers. What is important for you is in your clinical practice, you know that ACE inhibitors should not be given with ARBs. But for the super specialty exam point of view, you need to remember the trial, that is Valiant trial. Now, we had one more trial called the Atmosphere trial. What this Atmosphere trial said? Atmosphere trial, it supported the Valiant trial. But in Atmosphere trial, what is this Atmosphere? There is aliskiren trial to minimize the outcomes in patients with the heart failure. So what this particular trial has done is, they have taken almost 7,016 patients of the heart failure with reduced ejection fraction. To some group of individuals, right, what they have done, they have divided, to some group of individuals, they have just given only enalapril, right? Some group of individuals, they have given only enalapril. And some other group of individuals, they have added the combination, that is enalapril and as well as the aliskiren. Aliskiren is what? It is a direct renin inhibitor. Okay, it's a plasma renin inhibitor. So combination was given, right? So after the combination treatment, what was the result? In that particular study, it showed that combination treatment with enalapril and as well as aliskiren, it is associated with higher rates of, right? It is associated with higher rates of the hyperkalemia. It is associated with development of hypotension. It is associated with worsening of the renal function, right? But this combination did not show any incremental benefit. Okay, so there was no mortality benefit. Okay, so these two trials, Atmosphere trial and Valiant trial, showed that don't give the combination of ACE inhibitors or ARBs or direct renin inhibitors with the ACE inhibitors. Don't give the combination. That will further precipitate the hyperkalemia and the renal failure. Okay, so finally what said is, guidelines discouraged the combination of the ACE inhibitors and as well as the ARBs. Okay, and spironolactone in the heart failure with reduced ejection fraction. If at all you want to give ACE inhibitors plus spironolactone, okay, go ahead. ARBs plus spironolactone, okay, you go ahead. But these two you don't combine. That is what the guideline says. Okay, right. But again, whenever you are giving this combination of ACE inhibitor and spironolactone, also you need to do the strict monitoring of the potassium and you need to do strict monitoring of the renal function tests as well. Okay, right. So this was one group of drugs. Now let us just assume that the individual is unable to take these ACE inhibitors or ARBs because of potassium abnormality or because of renal impairment. You are unable to start the ACE inhibitors or angiotensin receptor blockers. Then in such case, you need to give the alternative vasodilators. The alternative vasodilators in heart failure with reduced ejection fraction, they include the following, that is your hydralazine and as well as the nitrates. They have been demonstrated to improve the survival in patients with heart failure with reduced ejection fraction. Now, if you take this hydralazine, mechanism of action, hydralazine, it reduces the systemic vascular tone. It will reduce the afterload on the heart, right? How it, so by reducing the systemic vascular resistance, it will induce the arterial vasodilatation, right? It will induce arterial vasodilatation. And how it does, how it will reduce the systemic vascular resistance. It will reduce the systemic vascular resistance by altering the intracellular calcium kinetics, right? By altering the intracellular calcium kinetics, right? You know, it will reduce the vascular resistance and it will induce the vasodilatation. So that is about the mechanism of action of the hydralazine. So hydralazine, it is also given as an antihypertensive. It is an arteriolar vasodilator. Then the other group of drugs was, that is the nitrates. So if you take the nitrates mechanism of action, these particular nitrates, they are transformed in smooth muscle right? They are transformed in smooth muscle into the nitric oxide, right? They are transformed in smooth muscle cells into nitric oxide, okay? Now this particular nitric oxide will stimulate the cyclic guanosine monophosphate, right? It will stimulate cyclic guanosine monophosphate. Now this cyclic guanosine monophosphate, that will cause the arterial venous vasodilatation, okay, and that will reduce the afterload on the heart, and that will reduce the mortality, and that will improve the survival. So this particular combination, right, if you see the combination of nitrates plus hydralazine, right, if you see this combination of nitrates plus hydralazine, remember this particular combination is also very much efficacious in patients with heart failure with reduced ejection fraction, but this combination is not superior, right? This combination is not superior compared to that of your ACE inhibitors plus spironolactone, okay? So definitely it is ACE inhibitors plus spironolactone only. Only when you are unable to give ACE inhibitors and spironolactone because of potassium impairment or renal impairment, then you need to give the combination of nitrates plus the hydralazine, okay? Right. So, right, the same thing again. So in individuals with heart failure with reduced ejection fraction, where the individual is unable to tolerate the RAS based therapy, what would be the reason for intolerance? That is hyperkalemia. Next is the renal failure. Okay, so these are the two parameters which tells the individual will not be able to tolerate the RAS. So in such case, the alternative is the nitrates and as well as the hydralazine. Okay, right. Now we have some trials regarding that combination as well. So that particular trials are AHEFT trial. What is this AHEFT trial? That stands for African American Heart Failure Trial, right? African American Heart Failure Trial. So in this particular trial, there was the fixed dose, right? Fixed dose of isosorbide dinitrate with hydralazine is given in the patients in advanced stages of the heart failure with reduced ejection fraction. Okay, right? These particular drugs was given in those patients who was already taking the ACE inhibitors and as well as the beta blockers. What this particular AHEFT trial demonstrated. So this particular trial demonstrated that when you are giving a combination of nitrates and hydralazine in patients already taking ACE inhibitors and as well as beta blockers, it demonstrated improvement in the survival. Right? It demonstrated improvement in the survival. Okay. And it also demonstrated reduction in the heart failure admission to the hospital. Okay. It also reduced the heart failure admission to the hospital. Okay. So this is about the trial, that is AHEFT trial. Okay. But only thing is, whenever you are giving this combination, that is isosorbide dinitrate plus the hydralazine, the problem is thrice daily regimen. Okay, you need to give 3 times. So this is one sort of limitation because the patient has to take 3 times. Okay, so this is about your nitrates and as well as the hydralazine. Now we have few more novel neurohormonal antagonists. They are the new one. Now what are these new? I'll tell you. Basically, what we are trying to neutralize in the previous drugs, what we have discussed was, we were trying to neutralize the RAS. We were trying to neutralize the sympathetic system. But apart from these neurohormonal antagonists, there are certain other pathways, right? There are certain other pathways by which you can neutralize this neurohormonal pathways, right? But the other pathways to cause the blockade, right? The other pathways to cause the blockade of the neurohormonal pathway was little question mark. Some they were having good survival, reduction in mortality, but some pathways they were unsuccessful. What are those? I'll discuss now. Okay. So basically what I'm trying to discuss in the novel neurohormonal antagonists is we have few more drugs apart from ACE inhibitors, ARBs, angiotensin receptor, apart from ACE inhibitors, ARBs and mineralocorticoid receptor antagonists and beta blockers. We have few more drugs which will neutralize these neurohormonal pathways, but some of them they're useful, some of them have been unsuccessful. What are those? Let me just give you an example. Like for example, we have endothelin receptor antagonist, that is bosentan, right? Bosentan, it is tried in patients with heart failure with reduced ejection fraction, okay, but it did not demonstrate any good outcome, right? It did not demonstrate any good outcome. In fact, it caused worsening of heart failure with reduced ejection fraction. But in which group of individuals it has shown the benefit is, it has shown the benefit in right-sided heart failure due to pulmonary hypertension, right? Right-sided heart failure due to pulmonary hypertension, in that group of individuals, the bosentan, that is endothelin receptor antagonist, was showing the efficacy, but not in patients with heart failure with reduced ejection fraction. One more drug, like centrally acting sympatholytic. See, basically you want to block the sympathetic nervous system, right? We have centrally acting sympatholytic drug, that is moxonidine. When you give moxonidine, this is also a neurohormonal antagonist, but this worsened, right? This worsened the outcome in heart failure patients, right? This worsened the outcomes in the heart failure patients, okay, particularly left heart failure patients, okay, right? Then one more drug, we have a trial called Overture trial. What they have tried in that, I'll tell you. So a combination drug was used here. What was that? That is omapatrelate. What is this omapatrelate? Omapatrelate, it is the combination of the ACE inhibitor, right? It is a combination of the ACE inhibitor with neutral endopeptidase inhibitor, okay, that is neprilysin, right? ACE inhibitor combined with neutral endopeptidase inhibitor. Okay, so this omapatrelate was given in one set of patients, and in another set of patients only enalapril was given, that is ACE inhibitor, only enalapril was given, that's all. So now what this study result have shown, let me tell you. So what was the name of the trial? That is Overture trial. So here omapatrelate was compared with only enalapril. This particular drug, that is omapatrelate, did not favorably influence the primary outcome, okay? So there was no good primary outcome, okay? So what was that primary outcome? The primary outcome is, number one, cardiovascular death. Number two, heart failure, hospitalization. Okay, so these two are the primary outcomes. Okay, so this particular omapatrelate did not show any particular favorable influence on the cardiovascular death of the individual or on the heart failure hospitalization. Okay, so what has been shown is, rather than giving omapatrelate, just give enalapril. That will be fine in reducing the mortality and improving the survival. But with this enalaprelate, okay, that is unilateral, one of the adverse effect is the angioedema. One of the adverse effect is dry cough. Okay, but this combination of neprilysin inhibitor and as well as the ACE inhibitor did not favor much, right? Did not favor much. Okay, and so the risk of angioedema with ACE inhibitors, right? With ACE, so when you are giving a combination of ACE inhibitors and as well as neprilysin inhibitor, the risk of angioedema was much more high, right? The risk of angioedema was much more high. Why is that? Because when you are giving neprilysin inhibitor and as well as the ACE inhibitor, that will cause the excessive blockade of bradykinin, right? So there was increased risk of angioedema. Why? Because there was excessive blockade, right? Because of the excessive blockade of bradykinin breakdown. So the bradykinin levels further increased whenever you give this combination. That is the reason why the risk of angioedema is more when you are giving these ACE inhibitors and as well as the neprilysin inhibitor, right? So blockade of angiotensin receptor, that is angiotensin receptor blockers, right? They can be combined with the neprilysin inhibitors. They can be combined with neprilysin inhibitors. But so when you combine angiotensin receptor blocker with neprilysin inhibitor, the ACE pathway is intact because your angiotensin receptor blocker will block the angiotensin 2. It will not block your angiotensin converting enzyme. So the ACE pathway is intact. So there is lower risk of angioedema when you combine ARBs with neprilysin inhibitor, but don't combine the ACE inhibitors with neprilysin inhibitors. Don't do that. The risk of angioedema further increases. Okay, so that is what is your overture trial, right? So accordingly, we have, so what this particular slide shows, you can combine angiotensin receptor blocker with neprilysin inhibitor, but not ACE inhibitor with neprilysin inhibitor. Okay. Now, a trial has come with combination of these two, that is ARBs with neprilysin inhibitor, and that particular trial is the Paradigm HF trial. So Paradigm HF trial, they have taken almost 8,399 patients of the heart failure with reduced ejection fraction, right? They have treated one group of individuals only with unilateral, another group of patients sacubitril plus valsartan was added. What the end result of this particular trial of your Paradigm HF? So one group only unilateral, the other group the valsartan plus sacubitril. Sacubitril is nothing but your neprilysin inhibitor. Okay, what was the result? So the result showed that in those group of individuals who are taking sacubitril valsartan compared to unilateral, this combination had showed 20% reduction in composite primary endpoints. What are those composite primary endpoints? Just now we were discussing, that is cardiovascular death and as well as the heart failure hospitalization. Okay, so this particular combination of sacubitril and valsartan that caused 20% reduction in the primary endpoint, and it also caused 16% reduction in all-cause mortality. And not only that, this particular combination also improved the quality of life of the individual. That is what is your Paradigm HF trial. But only thing, whenever you are giving this combination of this sacubitril and valsartan, you need to be very much careful about the potassium, right? Okay, so you need to monitor the potassium. Anyways, compared to your ACE inhibitors plus ARBs causing hyperkalemia, sacubitril plus valsartan, the chances of hyperkalemia is less. Okay, and you also need to monitor the renal function test because this particular combination also will cause worsening of the renal function. But the another important is there is high chance of, so hyperkalemia and renal function test, renal failure is less with this combination, but this combination has caused significant hypotension, right? When you compare this with unilateral, this combination of sacubitril plus valsartan has caused more hypotension. So that is what you need to be very much careful with. Okay, and the another point that you need to remember here is those individuals who has past history of angioedema, in those individuals your ARNI is contraindicated. ARNI is contraindicated in patients with prior history of angioedema, right? Then not only that, for suppose let us just assume that a patient is on ACE inhibitor, okay, heart failure with reduced ejection fraction, and he is on ACE inhibitor. Now you have known about this ARNI, so what you have to do? You stop this ACE inhibitor and you need to wait for almost 36 hours to start the ARNI. Okay, it is not that like you stop ACE inhibitor and start ARNI immediately. No. Stop ACE inhibitor, you need to wait for 36 hours, then you need to overlap with angiotensin receptor blocker and neprilysin inhibitor. Okay, so this is about the neprilysin inhibitor plus angiotensin receptor blocker, which is nothing but your paradigm HF trial. Okay, then now what are the various group of drugs which helps in the heart rate modification? So we have two drugs. One is your beta adrenergic receptor blockers, that is particularly beta 1 blockers, and the other one is the ivabradine. See, ivabradine, if you take the mechanism of action, ivabradine, it is inhibitor of the funny current channel, right? It is the inhibitor of the IF channel, inhibitor of the funny current channel, where within the SA node, right? It is the inhibitor of the funny current channel within the SA node. And this particular ivabradine, it selectively reduces the heart rate and it does not affect the contractility, right? It does not affect the contractility, or it does not affect the vascular tone, right? It does not affect the contractility and it does not affect the vascular tone, but it will reduce the heart rate of the individual, right? And it is what? It is the inhibitor of the funny current channel within the SA node. Now accordingly, for this ivabradine, we have a trial that is called as the SHIFT trial. What is this SHIFT trial? That is systolic heart failure treatment with ivabradine compared with placebo. So in this trial, the ivabradine was given in patients with NYHA class 2 or class 3, right, with prior heart failure hospitalization history, and the rhythm should be sinus rhythm, and in individuals with heart rate more than 70 per minute. Now, what was the end result of this particular SHIFT trial regarding the ivabradine when it is given in this group of, or in this clinical scenario? This particular study shown that ivabradine reduced the combined endpoint. Ivabradine reduced the cardiovascular death. Ivabradine also reduced the heart failure hospitalization. Okay, so both of them have been reduced by the ivabradine. Okay, so this particular study or this particular trial says that ivabradine can be given comfortably in heart failure with reduced ejection fraction when patient is in sinus rhythm, right? When patient is in sinus rhythm, okay, right? And this particular data, it shows that ivabradine can be given in sinus rhythm but not in case of the irregular rhythm. And this particular study says that you give ivabradine when the individual is unable to tolerate, right? The individual is unable to tolerate beta blockers, then you can give this ivabradine. Okay, what are the contraindications or where the beta blockers cannot be tolerated? Patient with COPD or patient with bronchial asthma, you cannot give beta blockers. Okay, and patient having hypotension, you cannot give beta blockers. Okay, in that place you give ivabradine. Ivabradine will not reduce the blood pressure of the individual. Ivabradine will not cause anything related to your respiratory system. So where beta blockers are not tolerated, there you give the ivabradine. Okay, right. So ivabradine in patients with heart failure with reduced ejection fraction, right? In those individuals who are taking the ACE inhibitors or ARBs or your ARNI, right? Then where the beta blockers cannot be given, and the patient is already on mineralocorticoid receptor antagonist, patient is in sinus rhythm, heart rate more than 70 beats per minute, you can give the ivabradine. Okay, you can give ivabradine. Okay, that means like the another point is like for suppose the individual is on maximum dose of beta blockers, right? Maximum dose of beta blockers, still heart rate is more than 70, then you can add ivabradine to your beta blockers also. You can add ivabradine to the beta blockers also. That is what is your guidelines regarding your ivabradine. And the next important group of drugs are the SGLT2 inhibitors. So if you take this SGLT2 inhibitors, what are those drugs? We have basically these drugs, they are given in the treatment of type 2 diabetes mellitus, right? And what is its mechanism of action in type 2 diabetes mellitus? It will inhibit the glucose absorption at the level of the proximal convoluted tubule, and it will cause the glucosuria. In that way, it is useful in the treatment of your type 2 diabetes mellitus, right? Now, this drugs, that is empagliflozin and as well as canagliflozin, they have been found to reduce the mortality in patients with heart failure with reduced ejection fraction. So, accordingly, we have some trials. Let me discuss that. So, this SGLT2 inhibitors, they have been shown to reduce the cardiovascular events. They have been shown to reduce the mortality among patients with type 2 diabetes mellitus who are having high, right, who are having high cardiovascular risk or who are having high atherosclerotic cardiovascular disease. So in that group of individuals, you can give this SGLT2 inhibitors, right? Comfortably you can give. They will reduce the mortality, particularly in diabetics, but they have also been tried in non-diabetics as well. There was a positive result. What are those trials? Let me discuss. So we have a trial called EMPA-REG outcome trial. Okay. So what is this EMPA-REG? That is empagliflozin cardiovascular outcome event trial in type 2 diabetes mellitus. So now what is this particular trial? So this particular trial has been done with empagliflozin given in heart failure with reduced ejection fraction, right? Some group of individuals were given empagliflozin, some they were just given only placebo. Now, according to this particular trial, what it shown is when you give and the patients are type 2 diabetic patients, right? Patients are type 2 diabetic patients. When you give this empagliflozin, that reduced mortality by 35% compared to that of placebo. That is what is the outcome of your EMPA-REG outcome trial. Okay, right. So what are the cardiovascular benefits of your SGLT2 inhibitors? Cardiovascular benefits, just now we have discussed. It will reduce the heart failure hospitalization and it will also reduce the cardiovascular events. But the cardiovascular benefits of SGLT2 inhibition is not dependent on, right? It is not dependent on the degree of reduction in the HbA1c. Whatever might be the HbA1c, either it is normal HbA1c or even it is increased HbA1c. SGLT2 inhibitors, they had a very good efficacy in patients with heart failure with reduced ejection fraction. And this particular study has shown that this SGLT2 inhibitors, right, can be given even in case of non-diabetes mellitus also. Okay, so there is heart failure benefit even without diabetes mellitus also, right? And we have another SGLT2 inhibitor, that is the dapagliflozin. So the name of the trial is the DAPA-HF trial. So in this, what the trial has been done, let me discuss. So they have taken almost 4,744 patients of heart failure with reduced ejection fraction who are like symptomatic, right? Symptomatic heart failure patients they have taken. So these patients already they are taking guideline directed medical therapy, that is they are on beta blockers, ACE inhibitors or ARBs, or like angiotensin receptor blocker neprilysin inhibitor, and as well as the spironolactone. Now to these patients, this study has added dapagliflozin. of how much dosage? That is 10 milligrams have been added to one group dapagliflozin and another group just only placebo. And this particular study was done for nearly around 18.2 months. Follow-up was done. Now, what was the result of this particular DAPA-HF study? The result showed that there is almost 26% reduction in the primary composite endpoints. So, what is that primary composite endpoint? That is, primary composite endpoint, it includes number 1, worsening of the heart failure, or number 2, death due to cardiovascular disease. Death due to cardiovascular disease. So 26% reduction in the primary composite endpoint was shown when dapagliflozin 10 milligram was added. Okay, and this study was done and efficacy was shown both in diabetics and as well as non-diabetics. So basically what this SGLT2 inhibitor says that is, what these drugs importance is that these drugs, they will not only reduce the mortality in a diabetic patients with heart failure, and even in non-diabetic patients with heart failure also the SGLT2 inhibitors can be given. Okay, we have one more study in order to reinforce this effect of dapagliflozin. One more study was the Emperor study, that is Emperor Reducer trial. Okay, so in this they have taken almost 3,730 heart failure with reduced ejection fraction symptomatic heart failure patients, where the ejection fraction was less than 40%, where the ejection fraction was less than 40%. So in them, like empagliflozin 10 milligrams once daily was added, and to certain other group the placebo was given. Now, what was the result of this Emperor reduced trial? See, basically this was the trial to reinforce the previous trials. So this particular trial was done for nearly around 16 months, follow-up was done, and this trial showed that in those individuals in whom empagliflozin was given, that showed almost 25% reduction in the primary composite endpoints. What is that primary composite endpoints? That is cardiovascular death and as well as the hospitalization for heart failure. Okay, so 25% reduction in the primary composite endpoint. Okay, and even this trial also showed this particular empagliflozin can be given in diabetic and as well as the non-diabetic patients as well. Okay, so together these studies have driven a consensus guidelines to consider SGLT2 inhibitors as one of the very important group of drugs, along with beta blockers, along with ACE inhibitors or angiotensin receptor blockers, along with mineralocorticoid receptor antagonists, and along with the ARNI. So you add even this also, the mortality was good. In the sense, the improvement in the survival was good. So that was about your SGLT2 inhibitors. Now we have one more group of drugs, and that particular drugs are soluble guanylyl cyclase stimulation. Okay, that is soluble guanylyl cyclase stimulation. What is its importance? Let me tell you. So this soluble guanylyl cyclase, it is the key enzyme of nitric oxide signaling pathway. Okay, it's a very key enzyme for nitric oxide signaling pathway. Okay, this nitric oxide, it catalyzes the synthesis of the cyclic GMP. It catalyzes the synthesis of the cyclic GMP, and this particular cyclic GMP, it will cause vasodilatation, And what is the example of your soluble guanylyl cyclase stimulator? The example is Vericigot. The example is what? Vericigot. So this Vericigot, it is associated with causing the vasodilatation. Now, because it is causing vasodilatation, it will reduce the afterload on the heart. Now, accordingly, there was a trial which has been done on this Vericigot, and that name of the trial is the Victoria trial. The name of the trial is the Victoria trial. Okay, so it is Verisegot global study in subjects with heart failure with reduced ejection fraction, that is called the Victoria trial. In this particular trial, almost 5050 patients of heart failure with reduced ejection fraction was taken. Okay, so they are either with chronic heart failure or the individual with NYHA class 2 or class 2 to 4 symptoms, ejection fraction less than 45%, elevated brain natriuretic peptide, evidence of worsening heart failure. So this particular group of patients were taken in this 5050. Now in this group of individuals, along with guideline directed medical management, right, GDMT stands for guideline directed medical management. So along with GDMT, what is the GDMT? Beta blockers, ACE inhibitors or ARBs, aldosterone antagonists, and then your ARNI. So along with this GDMT, Verisegot 10 milligrams were added, and the study was followed up for almost 11 months, right? The study was followed up for 11 months. What was the result of the study? So the primary study results were notable for modest 10% relative risk reduction in the primary composite endpoints. So basically this study was a positive study. So this study showed there was almost 10% reduction in the primary composite outcome. Okay, so what is that primary composite outcome? Same thing again, that is cardiovascular death, right, and heart failure hospitalization. Right, heart failure hospitalization. So in those individuals who have been assigned to Verisegot along with GDMT, that study showed almost 10% relative risk reduction in the primary composite endpoint. Okay, now this Verisegot, it is associated with low rates of the serious adverse effects. What is that serious adverse effects? That includes the hypotension, and even it can also cause the anemia. These are the adverse effects associated with Verisegot, but it is at a very low rate. So because it is associated with low rates of the serious adverse effects, that is the reason why it has been shown to be added as the adjunct to guideline directed medical therapy in high risk group of heart failure with reduced ejection fraction patients. So in high risk groups, this has been added, that is in advanced stages of the heart failure, but still the data is awaiting in the larger studies. So the guideline committees are still awaiting in the larger studies regarding this Verisegot, which is your SGC stimulator, right? Then the next important group of drugs are the myosin activation. So if you see this myosin activation, this is a novel approach. What is that myosin activator? I'll tell you. This myosin activation, what it does is, it will increase the ventricular systole, right? It will increase the ventricular systole, and thereby it will increase the cardiac output. And this myosin activators, they will not increase the myocardial contractility, right? What they will do, right? They will definitely increase the cardiac output. Then how do they increase the ventricular systole then? What they will do is, they will not increase the myocardial contractility. What they does is, they increase, right? They increase the ejection fraction and as well as the fractional shortening, and they are selective myosin activator. And what is that example of the selective myosin activator? That is omecamtiv mecarbil. Omecamtiv mecarbil, it is a selective myosin activator that will prolong the ejection fraction, right? That will prolong the ejection fraction, and it increases the fractional shortening, right? Without altering the force of contraction. So without altering the force of contraction, they will prolong the ejection fraction and it will also increase the fractional shortening. Okay, so this particular agent, that is omecamtiv mecarbil, right? This agent, it is distinct from the other inotropic agents. The other inotropic agents, they increase the force of contraction, but this, it will not increase the force of contraction. Now, because it is not increasing the force of contraction similar to that of other inotropic agents, this omecamtiv mecarbil, this is not associated with increased myocardial oxygen demand. Right? It is not associated with increased myocardial oxygen demand. So that is about your omecamtiv mecarbil. So what is the route of administration of this particular drug? This particular drug, it is available as the oral formulation, and it is also available as the intravenous preparation. Okay, so that is about your omecamtiv mecarbil. And we also have a trial on this omecamtiv mecarbil. The trial is the cosmic HF trial. Okay, that is chronic oral study of myosin activation to increase the contractility in heart failure. So in this particular trial, they have taken almost 448 patients of heart failure with reduced ejection fraction. Okay, and this particular trial had continued for up to 20 weeks, right? So treatment with omecamtiv mecarbil for 20 weeks. And when this drug was added, this particular drug has shown significant improvement in the cardiac function. Right? Significant improvement in the cardiac function. And this particular drug also had significant improvement in left ventricular remodeling. Right? Significant improvement in left ventricular remodeling. And not only that, this particular drug will also reduce the brain natriuretic peptide, and it will also reduce the atrial natriuretic peptide. So that was about the cosmic HF trial, which showed a positive result about this omecamtiv mecarbil, right? And if you take the safety profile of this omecamtiv mecarbil, that was compared with placebo, right? And it showed that there was no cardiac events, right? Despite there is a modest increase in the cardiac troponin in patients allocated with omecamtiv mecarbil, otherwise there was no significant cardiac events. Okay, so this particular study showed, that is cosmic HF trial showed, that is omecamtiv mecarbil, it has a very good result in heart failure with reduced ejection fraction. And we have one more trial. So this trial was done in a smaller group of patients, that is 448 patients only. That is the reason why a larger study using this omecamtiv mecarbil was done. So that particular study is galactic HF trial. Okay, so promising preliminary data fueled a larger clinical outcome trials. So in this trial, almost 8,256 patients with chronic heart failure, right, with chronic heart failure and ejection fraction less than 35% was taken and was randomized. So in this particular patient, omecamtiv mecarbil was given at a dosage of 25 to 50 milligrams twice daily. Right, 25 to 50 milligrams twice daily was given, right? So to one set of patients, omecamtiv mecarbil 25 to 50 milligrams twice daily. The another patients, there was just only placebo was given. So this was given along with guideline directed medical therapy. That means beta blockers, ACE inhibitors or ARBs, mineralocorticoid receptor antagonists, then RD was going on. Along with this omecamtiv mecarbil was given, and this particular study continued. See, the previous study, that is cosmic HF, was given for only 20 weeks, but this galactic HF, the study was continued for nearly up to 21.8 months, right? And it has shown that this omecamtiv mecarbil, whoever was taking 14% reduction in the primary composite endpoints. So what was that primary composite endpoints? The primary composite endpoints, that includes heart failure hospitalization and as well as the cardiovascular death. Right, heart failure hospitalization and as well as the cardiovascular death. So definitely the galactic HF and cosmic HF trial, both of them said this omecamtiv mecarbil is good in patients with the heart failure. And particularly this omecamtiv mecarbil is better tolerated and it has favorable safety profile, right? Favorable safety profile in late stage, right? In late stage disease, right? So this is very, very important point. Okay, that was about your omecamtiv mecarbil, right? Then followed by that, the role of digoxin. Okay, so digoxin, which is nothing but your digitalis glycoside, it has mild inotropic effect, that is contractility effect, and it reduces or it attenuates the carotid sinus baroreceptor activity, and it has sympathetic activity in the form of, right, in the form of sympatho-inhibitory activity, right, in the form of sympatho-inhibitory activity. That is the effect of digoxin on the heart. And a trial was done, and that particular trial is DIG trial, that is Digitalis Investigation Group trial. So this particular trial, what it demonstrated? It demonstrated a reduction, right? It demonstrated a reduction in the heart failure hospitalization, but there is no reduction in mortality. There is no improvement in the quality of life. Only it reduced heart failure hospitalizations, but this digoxin did not reduce the mortality and did not improve the quality of life. Okay, and if you take this digoxin, what this trial showed is treatment with digoxin, it resulted in higher mortality rate, right? Higher mortality rate. Okay, so that is the reason why digoxin is not used very commonly in patients with the heart failure. Okay, and if you take the dosage of the digitalis, it has a therapeutic index, therapeutic safety index. It should be noted that low doses of digoxin, they are sufficient and they have beneficial outcome then compared to that of the higher doses. Okay, so the low dose, the efficacy is good then compared to that of the high dose. Okay, and if you take this particular digoxin, in which scenarios we use this as the first line treatment, right? Actually, we don't use this digoxin very commonly, but in which group of individuals we use this digoxin, right? So this particular digoxin, it can be used in individuals already they are on guideline directed medical therapy, but still the patient is symptomatic, then you add digoxin, right? Then you add digoxin. That means the patient is already taking neurohormonal blockade, beta blockers, ACE inhibitors or ARBs, mineralocorticoid receptor antagonist, but still symptomatic, then you add digoxin. Patient is having adequate volume control, diuretics and everything is going on, but still patient is symptomatic, then you add digoxin. So when the individual is already on guideline directed therapy and as well as decongestive treatment, if the individual is still symptomatic, in them you need to add the digoxin. Otherwise, we don't add digoxin commonly, right? So for this volume control, what are the group of drugs that we need to add? That will be your diuretics. Okay, so if you take this particular diuretics, right, if you take this diuretics, you have to balance the dosage of the diuretics, because when you increase the dosage of the diuretics, that will further cause the neurohormonal activation. Because what the diuretics do? Diuretics will cause diuresis, there will be decrease in the fluid volume in the body, there will be hypotension, that will cause the activation of RAS, that will cause the activation of sympathetic activity. So you need to be very careful whenever you are giving this dosage of the diuretics. You need to balance that, otherwise it will further cause the neurohormonal activation. And this particular diuretic therapy, remember, they are only given for symptomatic treatment. Okay, only for symptomatic congestive symptoms, for them only you need to add the diuretic therapy. Okay, right? And what are the diuretic drugs you will add? That includes the loop diuretics and also the thiazide diuretics. Okay, right? Because when you add these loop diuretics or when you add these thiazide diuretics, what they do? They cause the renal sodium excretion, and thereby it will reduce the fluid levels. Right? Thereby it will reduce the fluid levels. So initially you need to start with the loop diuretics. Right? These are the preferred agents. Right? Then when will you add these thiazides? If the individual is refractory with loop diuretics. Right? If the individual is refractory with loop diuretics, then in them you need to add the thiazide diuretics. Right? In them you need to add the thiazide diuretics. Okay, right? Then if you take the loop diuretics, that is the furosemide, patients who fail to respond to furosemide at high doses, they require the transition to the other group of the loop diuretics. What is that? Only when the individual is given high doses of furosemide but still no response, then you have to give or you need to do the transition to torsemide, or the another alternative is the bumetanide. Right? The another alternative is bumetanide. Okay, right? So these diuretics, you need to remember that they don't improve the survival of the individual. They will only give symptomatic benefit. They are not at all useful for the improving the survival of the patient. Right? But as I have said you, the dose of the diuretics, it has to be balanced properly. Right? You need to balance the risk and as well as benefit, because when you are giving excessive dosage of the loop diuretics, that will enhance the neurohormonal activation and that will further worsen the clinical scenario of the individual. So that is the reason why loop diuretics or any diuretics when you are giving, you need to balance. And the thiazide diuretics, what is that we give is metolazone, or we have chlorthalidone. So when you are giving this combination of loop plus thiazide, it will cause the sequential blockade in the loop of sequential blockade in the nephron, and that will further increase the diuresis. Okay, right. Then coming to the calcium channel blockers. Calcium channel blockers, let me tell you, like we have first generation and second generation. Second generation calcium channel blockers are what? That includes, example, amlodipine, and the other drug is felodipine. So this amlodipine and as well as felodipine, they are the second generation calcium channel blockers, right? They are just given only to reduce the blood pressure of the individual. And this calcium channel blockers, they do not affect the mortality, they do not affect the quality of the life of the individual. Okay, so this amlodipine and felodipine, it has no effect in the heart failure with reduced ejection fraction, right? They don't improve the mortality. Whereas you take the first generation calcium channel blocker. The first generation calcium channel blocker is, we have verapamil and the other drug is the diltiazem. These two drugs, you know, they have negative inotropic effects. Right? They have negative inotropic effect. Okay. So because they have negative inotropic effect, they have to be discouraged in heart failure with reduced ejection fraction. Whereas amlodipine and felodipine can be given only to reduce the blood pressure, but not your first generation which has negative inotropic effects. Okay. So that is about your calcium channel blockers. Then coming to the another group of drugs, that is the anti-inflammatory therapy. So the anti-inflammatory therapies, what we have is, we have some drugs which will target the inflammatory cytokines, because the cytokines are also the one which will precipitate the heart failure with reduced ejection fraction. And this drugs which will target the inflammatory cytokines, what are those inflammatory cytokines? One of the inflammatory cytokines which can precipitate the heart failure with reduced ejection fraction is TNF alpha, right? So we give the TNF alpha inhibitors. Examples of the TNF alpha inhibitors are the infliximab and as well as the etanercept. So these two are having anti-cytokine property, right? These two are having anti-cytokine property, right? These two drugs, remember, they have been unsuccessful and associated with, right, associated with worsening of the heart failure, right? Associated with worsening of the heart failure. Okay, so at least can be given non-ischemic etiology. Remember, usage of intravenous immunoglobulin therapy in non-ischemic etiology of heart failure also has not been shown to result in beneficial outcome. So even in non-ischemic etiology also there is no beneficial outcome. So supplementing this anti-inflammatory therapy in cases of the heart failure with reduced ejection fraction, it is a question mark. There was no positive result, there was a negative result. And there are also trials. See, definitely from the clinical practice of point, you are very much aware that we don't give anti-inflammatory drugs, but you need to know the trials. The trials are the Acclaim-HF trial, the other one is the CANTOS trial. What is this? The Acclaim-HF stands for non-specific immunomodulation has been tested in advanced chronic heart failure, clinical assessment of the immunomodulation therapy, that is Acclaim-HF. CANTOS stands for canakinumab anti-inflammatory thrombosis outcome study, treatment of post-myocardial infarction patients with elevated high sensitivity C-reactive protein. So this is what is your Acclaim-HF and as well as the CANTOS trial. So both of these trials, like they have shown that there is no role of the anti-inflammatory drugs in case of the heart failure with reduced ejection fraction. Okay, right. The next group of drugs are the HMG-CoA reductase inhibitors, that is the statins. So if you take this particular statins, they are basically the drugs which are given for dyslipidemia. Okay, so they are the lipid altering drugs. So potent lipid alteration and potent pleiotropic effect of statins, they have shown to reduce the major cardiovascular events, right? They have shown to reduce major cardiovascular events and improve the survival, right? Improve the survival in non-heart failure patients. So you have to remember this, okay? What I am telling is in non-heart failure population, right? But once the heart failure is established, remember this particular statins, they have no role, right? Statins, they have no role once the heart failure has been established, right? And there are two trials regarding the statins. One is your Corona trial and the other one is GC-IHF trial. Okay, so if you take this Corona trial, right, that is controlled rosuvastatin multinational trial in heart failure, that is Corona trial. The other one is GC-IHF trial or GIS-IHF trial, that is Gruppo Italiano Parlo Studio della, right? So you can see this. So this is your GIS-IHF trial. So these are the two trials for the statins. What these trials have done is, in these two trials, low dose rosuvastatin was given, right? In which group of individuals? Heart failure with reduced ejection fraction. When low dose rosuvastatin was given in heart failure with reduced ejection fraction, this has shown no improvement. Right, this has shown no improvement in the clinical outcome in heart failure. Okay, so that is the reason why in heart failure, this HMG-CoA reductase inhibitors, they don't have much role. But in which group of individuals you can give is, see, indications of statin in heart failure is that if statins are required to treat progressive atherosclerotic vascular disease, or if there is significant dyslipidemia with the background history of heart failure, then you give that. Okay, so number one, if there is significant atherosclerotic vascular disease, right, or the patient is having significant, right, patient is having significant dyslipidemia in the background of the heart failure, right, in the background of heart failure, then you give this particular statins, okay. Otherwise, the statins, they have no role in heart failure with reduced ejection fraction, right. Then next group of drugs are anticoagulations and as well as the antiplatelet therapy, right. Remember, heart failure with reduced ejection fraction, it is one of the hypercoagulable state, right. It is one of the hypercoagulable state, right. Therefore, there is very high risk of thromboembolic events, including the ischemic stroke. There can be pulmonary embolism, there can be peripheral arterial embolism, right. So that is what is the status of heart failure with reduced ejection fraction. So that is the reason why is there role of anticoagulation in heart failure. What is the indication if so, right? If the patient with heart failure is having atrial fibrillation, then there is role of anticoagulation, and that too in atrial fibrillation we calculate the score, that is CHA2, DS2, VAS scoring system, and if the score is more than or equal to 1, then you need to start the anticoagulation, right? But data is insufficient about the usage of the warfarin in patients who was having normal sinus rhythm, okay. Heart failure with normal sinus rhythm, not required, anticoagulation is not required, okay. And not only that, the individual is having no past history of the thromboembolism. Why there is requirement of your anticoagulants? Not required. So only when the individual is in a state of atrial fibrillation with heart failure, then only you need to give the anticoagulation, right? So there was a trial done. That particular trial is the VARSEF trial. So in this, that is warfarin versus aspirin in reduced cardiac ejection fraction. So in one group of individuals, full dose of the aspirin was given. In another group of individuals, INR controlled warfarin was given, okay. So now what was the follow-up? The follow-up was done for almost 6 years. One group full dose aspirin, another group INR controlled warfarin. In which group? That is heart failure with reduced ejection fraction, and follow-up was done for nearly around 6 years. And what has been shown is, among patients with reduced ejection fraction in sinus rhythm, there was no significant overall difference in the primary outcome. So when you are giving these drugs in a state of a patient with normal sinus rhythm, then there was no difference whether you give aspirin, whether you give warfarin, both was same. But in a scenario of the atrial fibrillation, definitely warfarin has good role then compared to that of aspirin, depending upon the risk factors of the individual, okay. If your CHA2, okay, AF with CHA2 DS2 VAS scoring system, right, if this score, if it is more than 1, preferable to give warfarin rather than aspirin, right. Whereas in normal sinus rhythm patients, according to this trial, both of them, they have equal efficacy, right. And one more trial was done, that is on newer anticoagulants, that is direct oral anticoagulant, that is rivaroxaban. So a recent trial of direct oral anticoagulant, that is rivaroxaban, was given at low dose, that is 2.5 milligrams daily, low dose. This was given in patients with ischemic heart disease. This was given in patients with heart failure with reduced ejection fraction. This was given in patients with sinus rhythm. So whenever you give this rivaroxaban, this showed that there is no reduction in stroke. Right? There is no reduction in stroke. Okay. So that was about the report related to the rivaroxaban. And not only that, whenever you give aspirin in a case of patients with heart failure who is already taking, right, who is already taking the ACE inhibitor, right, aspirin in patients with heart failure who is already taking the ACE inhibitor. Remember, the aspirin, it will blunt, right, aspirin, it will blunt the activity of the ACE inhibitor. So preferably we avoid giving aspirin if the individual is in a state of normal sinus rhythm. Okay, so that is about the anticoagulation and as well as antiplatelet. So what is the end point? Heart failure with atrial fibrillation, give antiplatelet or give antiplatelet or anticoagulant depending upon your CHA2DS2 VAS scoring system. All right. Next is supplementation of the nutrients, that is like fish oil. Fish oil, it contains omega-3 polyunsaturated fatty acid. Okay, treatment with long chain omega-3 polyunsaturated fatty acid has been shown to be associated with improvement in the clinical outcome, right, improvement in the clinical outcome in heart failure with reduced ejection fraction, right. Clinical outcome was good and there was a trial done, and that particular trial is GC heart failure trial. Okay, this observation from GC heart failure trial was extended to measurement of, right, was extended to measurement of omega-3 polyunsaturated fatty acid at the baseline, what is the level of the phospholipids, and as well as after 3 months, what is the levels of your phospholipids. Okay, that was being studied by giving this omega-3 polyunsaturated fatty acids. Okay, so 3-month treatment with omega-3 polyunsaturated fatty acid have shown that there is increased levels of icosapentaenoic pentanoic acid and as well as docosahexaenoic acid. Okay, what is the importance of these? Remember, more is the levels of your EPA, less is the mortality. And again, inversely, less is the levels of your EPA, more is the mortality. So low EPA levels are inversely related to the total mortality. So low EPA, more is the mortality in patients with heart failure with reduced ejection fraction. So the study is shown that fish oil is very much effective, right? Then supplementing some micronutrients. Okay, there is an evidence suggesting that relation between the heart failure and as well as the micronutrients. Almost reversible heart failure has been described as a consequence of severe thiamine and as well as selenium deficiency. So in the micronutrients, what are very, very important is B1 and as well as selenium. Deficiency of this has caused heart failure, but that is reversible heart failure. So regarding the micronutrient supplementation, what are very, very important is the thiamine supplementation, that is B1, right, and as well as selenium supplementation is very important in improving the outcome in heart failure with reduced ejection fraction. And remember, these micronutrients have been found to be beneficial only in heart failure with reduced ejection fraction, but not in acute decompensated heart failure phenotype, right? But not in acute decompensated heart failure phenotype. Okay, so that is about your micronutrients. So what all we have discussed in this particular session is, right, all these drugs we have discussed, what is their importance and what are these various trials. In the next session, I'll just summarize, because we have discussed many trials, right? I'll just summarize all the trials of respective drugs, because what is important from the exam point of view, which trial, which particular drug, what is the end result, That is very, very important to be remembered. So with this, I'll wind up this session. Thank you very much. See you in the next session.